And I'd like to take a little break here and talk more about a disease process. Uh, and then we'll come back in 2 weeks. When I come back 2 weeks from Monday, we'll talk about inflammatory disease of the knee. But first, I'd like to give a talk about how to evaluate inflammatory disease with MR. So I'd like to talk a little bit about MRI and the evaluation of rheumatoid arthritis. So I'd like to talk a little bit about the historical perspective of rheumatoid arthritis, a little bit about what DMARD therapy is, disease-modifying anti-rheumatic drugs, pathophysiology of rheumatoid arthritis, or at least some theories, the roles that I think imaging should play in rheumatoid arthritis, and then talk a little bit about some of the controversies. So this is what we hope not to see anymore. At this stage, it's a very debilitating disease with a lot of limitations. And when I was in medical school, there really wasn't anything we could do about it. There are a few drugs like gold, which was shown to be minimally effective. In a classic study by a guy by the name of John Sharp, who developed a Sharp score for X-rays to actually show that gold was marginally effective at that time, became known as a Sharp score, and it was kind of the basis for the way rheumatology has really evaluated imaging studies ever since. He died last year, unfortunately. But we'll talk a little bit about that and some of the equivalent scores that are currently used in MR imaging for evaluating rheumatoid arthritis. Now we actually have treatment that's effective, so we really shouldn't see that anymore. But there are issues. So the older ones are golds and steroids. Steroids can be effective at stopping the disease temporarily, but the side effects are kind of horrendous. So it's not a very valuable treatment because the side effects, if you give enough steroids to be effective in rheumatoid arthritis, then you have all kinds of other complications that we're all aware of. The first really good drug for rheumatoid arthritis came out in the late 1980s, and it was methotrexate. And I can remember I was a house officer at that time. I did a rheumatology rotation. I couldn't believe that they were using a cancer drug on something as benign as rheumatoid arthritis. But you actually use low-dose methotrexate. The side effects are almost nil, and it's very inexpensive. It's a generic drug, so it costs about $700 a year for the treatment. So, and it became very effective, and it revolutionized the whole treatment of rheumatoid arthritis. So it actually became a treatable condition at that time, which then made imaging important for its evaluation.
That actually the oldest cancer drug there is, methotrexate. That was in the 60s, late 50s when it was started. It was very, very effective against choriocarcinoma. 98% effective for choriocarcinoma. But here it was produced in the 50s, and yet it wasn't used in this condition till the 90s. So kind of interesting, isn't it? And yet rheumatoid arthritis has a cancerous type of activity in many ways.
It spreads all around the body. Yeah. And it decreases life expectancy. The real difference here is that for cancers, it was used in high doses. For rheumatoid arthritis, it's in low doses, so it's a very different drug. They don't get sick like they do with high dose. They did at that time with high doses. And then around 2000, the biologic agents came out. These are antibodies that are produced against one of the uh, steps in the complement cascade. So it then blocks the ability to go through the complement cascades. Uh, these are much more expensive. They're much more expensive because they're much more expensive to produce, especially produce safely, because you actually have to, it's a biologic agent. It has to be created by a cell culture that can produce monoclonal antibodies against whatever entity it's against. And there are a number of different ones now. In the early days, there was just one. The one thing I just want to remember is that the nonsteroidals are not anti-inflammatory and they're not disease-modifying in rheumatoid arthritis. So this is one of the early papers, and there are several of them that showed the same thing, that if you treat individuals with rheumatoid arthritis who are newly diagnosed rheumatoid arthritis, if you don't treat, they have, on the average, they have erosions that increase as the years go along. If you give methotrexate, it tends to decrease the rate of erosive disease. But if you give the This etanercept is one of the first of the biologics, the first one that was FDA approved, one of the first ones. It has a significant impact above and beyond what methotrexate has. The tumor necrosis alpha inhibitors, which is what the first ones are, an antibody against tumor necrosis alpha, uh, have a preferential impact upon decreasing the bone disease and the bone erosion disease, which is very valuable, but it can also be very helpful for the symptoms as well. So we'll go through a lot of controversy, but there is general agreement on a few basic principles. One is that the long-term disability strongly correlates with the amount of bone destruction. So one of the mainstays in keeping people active and functional is to decrease the bone destruction or the erosions. Another one that people tend to forget about is that a regular rheumatoid arthritis, even if you don't treat it, only about 50% of patients will develop progressive erosive disease. So they may all develop symptoms, but not everybody actually has bone destruction. So it's really a subset here that we're going to be most interested in, certainly from an imaging standpoint. The treatment with disease-modifying drugs are effective at slowing or stopping the progression of the disease. And there's some papers to suggest if you treat it very early on, you may cure the disease and abort the disease. And also what's clearly shown now in a number of studies, early diagnosis and treatment improves the outcomes in these patients. So if you go to most places in the world, like Europe and Australia, New Zealand, they have programs now where they're going out into the community to try to educate people as to the early signs of rheumatoid arthritis, so they can be diagnosed at an early stage and treated at an early stage, which improves outcomes, and you can also tend to get by with less expensive drugs in that area. Those kind of programs in the United States really don't exist much. And so one of the reasons why a lot of the research on these are done elsewhere, and if you look in the rheumatology literature, 90% of all the research in MRI and rheumatoid arthritis is from outside the United States, is that we don't have those programs in the United States. And that's primarily because there's a different way in which medicine is funded outside the United States versus inside the United States. So let's talk about the pathophysiology of rheumatoid arthritis. And this is not completely agreed upon, but one of the theories that's fairly prevalent is that it starts with synovial inflammation. The inciting event is not clearly understood, but it starts with synovial inflammation. Then what happens is that the bone marrow adjacent to where the synovium attaches to the bone, that's the capsular insertion at the margin of the bone, uh, the marrow fat cells get replaced by inflammatory cells, and it's a true osteitis. And it's unclear whether there is something that the synovium secretes that then brings inflammatory cells in from the vascular space in the bone, or whether there are small fractures in the attachment of the capsule, which allows this inflammatory cells to extend through the cracks in the bone into the medullary space. And that's debated, and there's nobody really knows at this point. But what we do know is that, and I'll show you the studies for that, that you develop a true osteitis. In the rheumatology literature, it's called bone marrow edema, BMEs, but we now know it's not just increased extracellular fluid, and that's important. It's really inflammatory cells. The reason that's important is that it's a true inflammatory condition. If you treat it with anti-inflammatories, it goes away. And the thing that I keep emphasizing is that if you treat it early enough, you'll have a reversible lesion at that point. But if you wait to a certain stage that we'll talk about, it becomes irreversible. So it's important to diagnose these early. And that's one of the main arguments I make for the use of MR, and we'll get to that. Then what you get with osteitis, you get resorption of the trabecular bone by the inflammatory cells and the inflammatory exudate that they produce, the chemicals. You dissolve the trabecular bone. Once you've destroyed a trabecular bone, it can't grow back again because it has no substrate. These are plates and spicules. I should have given the bone lecture first, but anyway, they're plate and spicules. Once you destroy them, there's no blueprint, and you end up with a hole in the bone, which we call a geode, and that's really the source of the geode. If you pick it up early enough, however, then you can stop the destruction, and then it'll remodel in the normal process and can become normal bone again. Once you destroy the trabecular bone, then the inflammation, if it is allowed to continue, it'll then destroy the cortex of the bone near the capsular insertion, and that's what we call an erosion. And you can see at this point, you can see it by CT or plain films. Before this stage, you cannot see it by CT or plain films. And before this stage, you can't see it by ultrasound either. So we'll get to why that's important. Then then once you get the erosion at the capsular insertion, if it continues, it will then begin eroding the subchondral bone underlying the articular cartilage. Once you've destroyed the bone underlying the articular cartilage, there's no nice surface for the cartilage to sit on, and the cartilage becomes destroyed. And then you go into degenerative joint disease with articular cartilage destruction and joint disease. So I'm going to go through these 6 stages of the disease process. So the first stage would be the synovial inflammation. You get inflammatory cells and neovascularity. These aren't normal capillaries, they are neovascular capillaries. And you can see this as increased vascularity with power Doppler or perfusion MRI, or the evaluation within 1 minute of giving a bolus injection. Very similar to the same way you look for cancer. Cancer in the breast on an MR scan enhances in the first minute. After that, it's usually more chronic inflammation or benign disease. And this shows that you have high activity. And therefore, with acute high activity, then you have a real risk of destroying bone. The next stage is a subacute stage where by histology you get inflammatory cells, but mostly stromal cells and normal capillaries. This can be seen as synovial thickening by ultrasound and a regular equilibrium phase contrast enhancement. It's just synovial thickening. And this can be active, not active, moderately active. But when as all you see is just thickening of the synovium and not early enhancement, you tend not to get much progression of the disease process. And then you can get chronic disease where you basically have very few inflammatory cells. It's mainly fibrous tissue at histology, and then you still get thickening by ultrasound and MRI, and that's a kind of a burned out stage, which is no longer active as an inflammatory process. So what does this look like? This is an enhancement on a 1 Tesla uh, extremity magnet. This is 12 seconds after the bolus injection. Now, this is an article using a low field scanner, actually, by Semino from Italy, and they did a number of studies where they published that the early enhancement within a minute, correlates with active inflammation. And this has been used in animal studies now, because this acute inflammatory stage, if you can see if you have a drug that's actively is a good anti-inflammatory drug, and you have a synovial inflammation that's active at this early stage in the perfusion stage, then within 1 to 2 weeks, the early perfusion enhancement will go away if you have a drug that's effective. And the first studies that were done to prove that TNF-alpha inhibitors were effective, it took 6 years to do the study, because it took 6 years to get statistically significant changes on the way they were monitoring the disease process, which was basically X-rays and erosions. Now, with using perfusion MRI, we can see changes within a week or two. So it's really helped in screening drugs in animal models. So if you look at this area, there's a little bit of synovial thickening there, but at 12 seconds, you don't see any enhancement. 24 seconds, now we're seeing early enhancement. So that's acute inflammation. By 36 seconds, it's markedly enhancing in that area. There are other areas of synovial thickening which aren't enhancing early, which are probably more chronic changes. Here, most people, when they do contrast enhancement, they do equilibrium phase. They usually enhance several minutes after they image several minutes after giving the bolus injection. And there's just a case where we have enhancement of the synovium here in the distal radial ulnar joint, typical of kind of what most people will call this synovitis, but it's not really an active form of synovitis, really, unless you do early imaging. The problem is most people don't like to do time intensity curves and do imaging very early on. It takes kind of special techniques, which everybody can do. It's still just kind of a pain in the ass to do it. So most people and most of the international criteria for using MR to evaluate joints use the equilibrium phase enhancement, not the early phase enhancement. So that's kind of the synovial enhancement. And the bottom line is, I think we'll talk about some of the studies later, their synovial thickening is very common in rheumatoid arthritis, as you would guess, but it's not a very good predictor of future disease. And that's because almost all the studies have looked at the equilibrium phase, where most of those people probably have minimally active synovitis. It's just synovial thickening. It's chronic and probably was active at some earlier time. There aren't very many studies that have followed patients over time using the early phase enhancement. And by the way, many people now are recommending using Doppler ultrasound to do this because it gives you basically the same information as the early enhanced MR. And so that might be a good way to evaluate some patients. The next is the marrow inflammation or the osteitis phase. Again, it's very important. I really emphasize you should call it osteitis, but everything you'll see in the rheumatology literature will be BMEs or bone marrow edema. The reason is that I think this is the early stage of erosion. Kind of by definition in rheumatology, it's not an erosion unless you can see it on an X-ray, or in other words, until you have the cortical interruption, which is well past the reversible stage. So I really think that we ought to think of the early erosion as an erosion that's negative on X-rays, but is really the osteitis phase, because that's the beginning of the inflammatory phase, because that's what you can treat, and actually the patient can go back to normal, at least as far as the bone's concerned. So the concept that it's inflammation, I think, is important because it's a treatable lesion. But these are highly predictive of bone destruction at 6-year follow-up, and there are a number of papers that have shown that the osteitis lesions, and these are right next to the capsular insertion, that these are very highly predictive of the future development of X-ray detectable bone erosions. So this is an example. This is on a low field scanner. Here we can see an area of a little bit of decreased signal intensity on the T1 weighted image, which is bright on the STIR image. And so this is what osteitis looks like. The margins tend to be indistinct, and it's just kind of gray on the T1 weighted images. So indistinct margins. So that's the typical appearance of osteitis. The one paper has shown that high field is more sensitive. It turns out most studies, when you look at different field strengths, if you do the imaging properly, then they both can pick these up very nicely. It's not a matter of spatial resolution. The one paper that didn't show it is a paper that didn't have a STIR sequence in it. So if you don't have a sequence that can detect edema, then obviously you're not going to see it. This is a reversible stage of the disease. And therefore, it's important to pick up one. We know it's very predictive. It's also highly diagnostic of rheumatoid arthritis, as opposed to just the cysts and nonspecific post-traumatic changes that you can also see. And if you treat it, it goes away. So I think it's important. And this is just a paper that Eva Olick, who's, I guess, now in Las Vegas. She was in Oklahoma, University of Oklahoma, when we did this paper a couple of years ago. This is very specific for rheumatoid arthritis. Now, this just shows this is this is on a low field. This is one that we don't even use anymore, a desktop MRI called MagniView. We can see a little area of edema there on the T1 weighted image. On the CT, this is a high resolution CT, multidector CT. It's perfectly normal. And you can't see these early lesions that are just osteitis. You can't see anything on an X-ray until you destroy enough bone to have a change in the amount of mineralization. So here's actually a 1.5 Tesla scan, and we can see many different stages. This is the osteitis stage. This is kind of an intermittent stage of erosion where you can see sharp margins. The osteitis, you have indistinct margins. With a fully developed erosion, you have very sharp margin. And then when it becomes old and kind of burned out and fibrotic, it's low in signal intensity. So you can kind of see 3 different stages of erosive disease there. And that's the osteitis stage there, which is the important stage. And that's an old one. Now, Then trabecular injury. And I like to think of this the same way as you think of a brain infarct. So if you look at an infarct in the brain, you occlude a vessel to the brain, what happens is you get a large area of ischemia. And the most ischemic part is in the center because in the periphery of the distribution of that vessel, you can get collateral flow from other vessels. So you kind of have a gradient of injury. And the longer you allow that vessel to be obstructed, the more dead tissue you'll see in the brain. And dead tissue is irreversible. It's not going to come back again. But as you know, you have an umbra in the middle of dead tissue. Around the periphery, you can have stunned brain that's not functional, but it's not dead. And there, if you reperfuse and get blood flow to it, you can preserve that brain. So the reason that we try to detect these early on, get people in and do TPA or some other type of declotting process is to preserve as much functional brain as possible. The same thing I think occurs in rheumatoid arthritis in the bone. And that what will come in is that you'll see an area on MR where you'll have marrow edema. But in the central part of that, you will have kind of maximum destruction of the trabecular bone. And as you go to the periphery of the edema area, you'll have involvement of the trabecular bone, but a lot of it will still be intact. And therefore, the sooner you treat, the more of that peripheral bone that's just at the periphery of the inflammation will be kept intact. And you may end up with just a very central focus that may have irreversible destruction of the trabecular bone. So, so, uh, so if you have complete disruption of the bone, it's irreversible. If you have partial disruption, but the trabecular is still intact, that's reversible and that can remodel again and become normal. The important thing to remember is that the rate of the destruction is measured in weeks and not in years. So if you come in with an osteitis lesion, we know that very commonly you go from osteitis to an X-ray detectable erosion in the span of 1 to 2 years. But most likely what happens is you can go from an area of inflammation with intact trabecula to inflammation with destroyed central trabecula in a matter of weeks or months. And then it takes a lot longer to actually destroy the cortex of the bone before you can actually see a lesion on the X-ray. CT would pick it up earlier. So it's important to treat these early. And therefore, most people now feel that once you make the diagnosis of rheumatoid arthritis, if you see that it's an inflammatory disease, you need to treat immediately. In the old days, the concept was, well, we'll go through a whole system of treatment. You kind of treat with aspirin and nonsteroidals, which doesn't treat anything, maybe make them feel a little bit better. Then you can start on methotrexate, and you wait 6 months to a year and see if there's any bone erosions. And then finally, if they continue to be symptomatic and eroding bone 2 to 3 years later, you start them on the TNF-alpha inhibitors. But by that time, what's happened is within 2 to 3 years of initial diagnosis, a substantial amount of bone destruction occurs in that time period. So if you're actually going to improve prognosis, it's now believed you need to treat early. In fact, most people believe you have to treat now immediately upon making the diagnosis. And the question is, what do you treat with? Well, you generally always treat with methotrexate. The question is whether you need to add TNF-alpha inhibitor, which is another $15,000 a year drug treatment. So that's really the issue. And if you don't have, if most of these patients will get better on methotrexate alone, but as we'll see in some later slides, that doesn't stop all the inflammation. So if you have substantial bone osteitis, many people now believe that you have to be treated with a TNF-alpha inhibitor or one of the other biologics at the same time to stop the process. And then now it was believed once you started on a biologic, you had to always stay on the biologic. And the drug companies really like to push that. But generally now it's thought you can start, you can stop the process, you can back off on the expensive biologic, you may be able to maintain them on methotrexate. But then the issue is, when are they going to go? How do you know how well they're doing? So people then thought, well, we can just treat clinically. Turns out you can't do that, but we'll get to that later in this talk. So this is really important in terms of maximizing the outcome of patients. Outside the U.S., people are much more aggressive than inside the United States. So here's an example. Here we can see an erosion in the distal ulna. This is on 12/21/05. At this time, the patient was started on a TNF alpha inhibitor. And if we follow this, this is now over a year later, and you can see it's decreased in size.
I don't like that. I thought you said once the trabeculae were gone, that there's no way for the bone to grow back because the septi are gone. Am I misunderstanding something there?
So what's happening here? So, very good question. I'm glad I planted you in the audience. So the general feeling was that erosions cannot get better for the reason you just described. If you destroyed the bone, it's not going to grow back again. So what's happening here? I think what's happening here, and the reason I kind of thought of that theory that I just proposed is, I think when you see this lesion on the left, not all the trabecular bone has been destroyed in here, that you have a gradient of destruction that's completely destroyed in the center, but the areas around the periphery where the trabecular are still intact. You just have inflammatory cells around it, and your signal is coming from the inflammatory cells, not the trabecular bone. When you treat it, you get rid of the inflammation. The area that you still have trabecular bone there becomes normal again, just like we talked about. But where you've completely destroyed the trabecular bone, it's not normal. It's irreversible. So we found in the study that Oren Traum and I published a number of years ago in J. Room that about 15% of his patients, once they were started on TNF alpha inhibitor, we saw a substantial decrease in erosions. Most of them didn't go away, though some of them did. Most of them just got better. But I think what's happening is that we're basically preserving that penumbra of injury. And therefore, as you can see, the sooner you catch it, the more bone you're going to preserve.
Well, one is the that's in the '05 study, and the other is a true erosion. Um, and how about the fluid inside the joint space of the carpal row? Can you actually see the fluid very well with a low field scanner?
You can, but you have to have a stir sequence, and I'm not sure I have the stir sequence with this. Yeah, I don't think I have the stir sequence, but you can, yes.
The fluid inside the joint, which is encapsulated, obviously, increases the pressure of the joint. And it's almost like a herniation plus an erosive change that destroys the trabecular bone. I'm not sure how much the disease is, what the disease causes, synovial hypertrophy.
Yuri,
Yeah, there.
you want to turn your mic off? Thanks. Uh, that
Yeah, I just lost you for a second, and I had to reconnect. Just wanted to let you know I was
Thank you.
having the same problems.
Okay,
Thanks.
thank you. I'll keep talking with them. That concept of the pressure is one that's in almost all the orthopedic textbooks. That's no longer considered the primary cause. More recent studies believe that the cause is more the destruction that we have here. But we'll talk more about geodes later. But I think the erosions here, for a number of reasons, are not pressure from the synovial fluid. It's true inflammation of the bone, and that's what all the histology studies now show.
Well, I think you can have both. Because every joint I've ever operated on, and I've done my share of rheumatoids, you see a lot of fluid in the joint.
You see
You
fluid.
see the fluid going right into the eroded bone.
Yeah, most of the histology studies that I know of in the MR studies don't show fluid going into most of the rheumatoid erosions.
Histology won't show the fluid because the fluid leaks out as you put the.
Well, so what histology shows is that it's filled with inflammatory tissue.
Oh yeah.
There's not a space there for the synovium to go into.
So you don't actually see that.
Yeah, it's not. You don't have joint fluid going into these. These are not filled with joint fluid. Yeah, they don't communicate. Most of these don't communicate with the joint space. Yeah. So so this is what we're just talking about. Now let's go on to the cortical destruction phase. And again, remember, this is theory here. There's bits and spattering of data that support this, but you You can't say that this concept of disease is ironclad right now. This is a theory. So next would be cortical destruction, and therefore if the erosion stays long enough, it will destroy trabecular bone, but it will also go through the cortex of the bone. Now, this was a study from Donegal et al. In Arthritis and Rheumatism from 2007, where they actually placed the early erosions here between the capsular insertion and the articular cartilage, which is what was believed to be the primary case for a long time. This is some old study. They then came out with a paper in 2009 where they actually said, you know, when they looked at the real details, these are associated with micro damage, but it's right at the capsular insertion. It's not in between the two. So it's right here where the capsule inserts. And there are a number of studies that suggest that trauma plays a role here as well. You tend to have the most prevalent erosions at capsular insertions that in the normal function day-to-day life have the highest strains on them. So they tend to be like the second, the ulnar side of the second metacarpal head, and right around the second and third metacarpal heads are very common locations. And so it may very well be that micro trauma at the capsular insertion may play a role, which gets back to the fact maybe it starts in the synovium, maybe the inflammatory cells go through defects that occurred due to traction injuries at the capsular insertion to populate the bone and then start destroying the bone. But anyway, those are all theories right now.
Activity of daily living.
Yeah. Activity of daily living. So what do erosions look like? Let's see, Sheila, where are the erosions here?
So I do see one in the third proximal phalanx at the ulnar aspect of the metacarpophalangeal joint. Yes, and also in the fourth.
Okay, here's the MR, and here's where the erosions are. And the bottom thing to realize, and all the papers have shown this, MR is far more sensitive than X-rays are. And actually, I think the literature, I think X-rays are much less sensitive than really in the literature. In the studies that we've seen comparing MR and X-rays, I find that MR is very insensitive. One study says that for every 9 erosions seen by MR, you'll see 1 by X-rays, but it's probably somewhere in that range. But most of the publications show that it's maybe 3 to 1 or something like that. But there are a substantial number of patients that will have erosions by MR and not have erosions anywhere detectable by X-rays. The bottom line is MR is much more sensitive. Everyone generally agrees with that. The argument has been, well, they're not true erosions unless you can see them by X-ray, and therefore we'll discount the MR findings. But we've gotten away from doing X-rays in every other bone disease we know, except for occasionally we're used to differentiate the different kinds of tumors, but even there, X-rays are actually, the only reason we do them is because people have 100 years of experience with it, not because the actual data is very robust. But it's just now getting to the point where the FDA is beginning to accept MR data in clinical trials. Up until this last year, the FDA would not accept MR data in clinical trials. You had to use X-rays, and X-rays won't show disease for 2 to 6 years after you actually have inflammatory disease. Europe embraced MR much more readily than the US. The reason for that is probably economic and has to do with turf battles, but we won't get into that here. Okay, here's a study. This is the study that Eva Olick and I published a couple of years ago. It's really Eva did all the work. We looked at 40 RA patients and 40 healthy controls. We found that a single erosion was 90% sensitive for rheumatoid arthritis when we used all the clinical information to make the diagnosis, but not very specific, not too big of a surprise. Osteitis was 65% sensitive, but a number of patients with rheumatoid arthritis did not have osteitis, but it was much more specific for RA. The interesting thing about it, however, is that when you scored these, the first time it was scored, we used a RAMRIS score, which is from OMRAC. It's an internationally accepted scoring system for rheumatoid arthritis that's used in clinical trials now around the world. But the problem with that is the erosion, bony changes wherever they are really scored the same. If, however, we eliminated the lunate because of the high prevalence of ulnar abutment syndrome, if we eliminated the lunate, sensitivity dropped, but the specificity went way up. And a lot of the reasons why we have a low specificity for RA is I think a lot of these patients had ulnar abutment, which was scored as an erosion. And then concluded that MR was useful in following patients with rheumatoid arthritis because it was a more rational way to determine treatment. Next, let's go to bone destruction of the subchondral bone. So you get an erosion, then what can happen if you continue to allow the inflammation to progress is that the erosion can increase. So here we have in 112103, we can see a marginal erosion here on the right near the capsular insertion, just like we talked about. Here, 4 years later, notice how it has progressed, and now it's eroded the subchondral bone where the articular cartilage sits. Here's another example. Here we can see pencil and cup deformity, an old classic X-ray finding, but here you can see the erosion probably started here from the mechanism we talked about. It's eroded the subchondral bone here, and now we just have a little tiny spicular bone, so all the force through this joint is going through this little tiny area, so the pressure is enormous at that point, and you destroy the bone. So again, we believe it's very important to detect these early, treat to stop this process before you end up destroying the subchondral bone and the articular cartilage.
What I always found interesting when you operate on these folks, the capsule is intact. It may be stretched, but they're intact, and yet the bone is gone. It's
You mean replacing?
awful disease.
You were doing joint replacement?
Yes.
When you were,
Well, we'll see some of those.
I don't understand though. Are these patients getting imaged generally when they're symptomatic or to follow up and see how they're evolving, like their rheumatoid?
We'll talk about that later, and it depends upon where you are and who you're arguing with, and who's paying for it. So, but let's talk about that in a minute, so we can see where it progressed there. And of course, this is what you'd like to not see, and now we can pick all this stuff up early, and there's no reason, since we have effective drugs anymore, to see this kind of a condition where the whole wrist is destroyed by the pannus formation. So let's talk about some of the non-erosive forms of rheumatoid arthritis, and then we'll come back to clinically how to handle some of this information. So other weird things that you can see with rheumatoid arthritis is fusions. You can see osteoarthritis because of the destruction of the articular cartilage and the laxity you get. One of the things that rheumatoid arthritis does is that the inflammation also causes the capsule to stretch, like John just said, which leads to instability of the joints. You have micro instability, and it means you can get more banging of the cartilage and there more wear and tear on the cartilage. So you can see osteoarthritis from the destruction of the subchondral bone and from the laxity due to stretching of the capsule. And then you can also see ulnar impingement. So here's bony fusion. You get some really weird structures here. You can actually have all the bones fuse in the wrist. How does that occur? Well, this is a low field scanner, but this just kind of shows what happens. Here is 12607, and we can see osteitis involving the proximal part of the capitate, and maybe to a little lesser extent here the scaphoid. But notice that there is a joint space intact here with a lot of synovial thickening and a lot of osteitis in the other bones here. All these bones have osteitis in them on this low field scanner, but the joint space is intact, 12607. And there you can see on the axial images the intact joint space. Now we go to 2009. Now there's actually marrow space spanning this area. Notice that the osteitis has gone away. We no longer have the edema within the bones. Large part of that's probably now it's fused and you don't have the trauma associated with it. And on the axial images, you can see the bone fusion there. So typically when you get osteitis on both sides of a joint where the two are together, you get just eating through the cortex, and then you can have the bone fuse. Very common. You can see it all kinds of places in the body with rheumatoid arthritis, but especially in the toes and in the wrist and in the hand. And then that leads to abnormal joint mechanics and then more progressive degenerative joint disease. So synovitis leads to osteitis, leads to fusion and then dysfunction. Now, ulnar impingement is something else you can see in rheumatoid arthritis. Here, if you get an erosion that eats away the distal end of the ulna, or if you have a resection of the distal part of the ulna for inflammatory disease, what happens is you get abnormal articulation between the distal ulna and a more proximal portion of the radius, and you'll develop a kind of a fossa there. We can see all this synovial thickening in that area, and that's ulnar impingement. We'll see more examples of this and several different characteristics of ulnar impingement when we get to the wrist lectures. And then we can look for the soft tissues. MR is great for looking at all these conditions, and it's really only MR can look at all of these together. You know, ultrasound can see a few, CT can see a few, X-ray can maybe see a few. But let's go through some of the soft tissue injuries. So first we can look at the ligament laxity that I just talked about. Very commonly you'll see volar subluxation of the metacarpals the phalanges with respect to the metacarpals. It can be all of the joints or just some of them, and you can see why that leads to destruction of the cartilage and degenerative joint disease. You can get tenosynovitis. Here we can just see a lot of inflammatory condition around the extensor carpi ulnaris tendon, which is involved in over 50% of all patients with rheumatoid arthritis, probably closer to 70%, and there we can see the synovial thickening there. Usually the involvement, however, is subluxation rather than this kind of inflammation. And here we can see a dislocation of the extensor carpi ulnaris, which is abnormal in configuration and signal intensity. This is very common. In young athletes, these are very highly symptomatic lesions, produce a lot of pain. In rheumatoid patients, they're almost always clinically unimportant and without symptoms. Now, other things that you can see with MR, you can see flexion of the proximal interphalangeal joint, extension of the distal interphalangeal joint. Anybody know the name for this? Okay, boutonniere deformity. Very good. You can also see the opposite. Extension proximally, flexion distally, and these are fixed deformities. You know what? Swan neck, and that's a swan neck deformity. And the reason that these occur is that the kind of the capsule in the synovium that holds the extensor tendons in proper position on the bones get eaten away and they sublux, just like we saw with the ECU. Then when they sublux, they pull from a wrong direction, and therefore even if you fire muscles normally, because the tendons are pulling from an incorrect direction, you end up with these fixed deformities that they can't change but by their own muscles. And then this one, anybody know this one? Flexion of the thumb, extension of the interphalangeal joint. Man, again, we can see displacement. And that's a hitchhiker's thumb. So things.
That's beyond.
Yes. Yeah. Yeah.
There's another like congenital dysplasia that they have, the hitchhiker's thumb too, but I don't know.
Well, maybe you can tell us about that next time. Alrighty. Okay, and then this is a patient with long-standing JRA. It's an adult at this stage. You can see destruction of the glenohumeral joint space there, but the main thing here, notice that there are these big collections that look like lymph nodes there. And this patient, these were the rheumatoid nodules. And then here you can see the thickened synovium within the shoulder joint space and chronic inflammatory changes. So what do we use all this information for? Well, again, it's important for early diagnosis for all the reasons I kind of went through. Most people now believe it's important to make an early diagnosis of rheumatoid arthritis and treat immediately. And the American College of Rheumatology and EULAR, the European Union, it's the European League Against Rheumatism, EULAR, that's the European Rheumatoid Society, which is actually the largest one in the world, got together to change the criteria for defining rheumatoid arthritis to try to make the diagnosis early, since there's overwhelming information now that early diagnosis and treatment gives much better outcomes. And though it's controversial in the United States, it's pretty well established in Europe that MR can be helpful in defining and diagnosing early rheumatoid arthritis, and I'll explain how in a minute. It could also predict erosive phenotype, which is the phenotype that you need to treat with anti-inflammatory, with the biologic agents. Then MR can detect and quantify synovial inflammation, and it can evaluate cartilage and other soft tissue injuries. So let's start with early diagnosis. Here's a study from Japan. What is the value of MRI and ultrasound evaluating patients with undifferentiated arthritis? What they found, there's a group called undifferentiated arthritis, or basically a group of people who come in with inflammatory joint disease, but they don't fit all the criteria for rheumatoid arthritis. Many of them will get better and be cured with nothing. Some will go on to develop rheumatoid arthritis and all the definitive treatments later. So the question is, how can you find at this stage, determine who's going to get rheumatoid arthritis and who's not, so you can treat them early? And what they found is if you did an anti-CCP and an MR which showed osteitis, that had a 100% positive predictive value, that all of those patients that had those two findings would go on to rheumatoid arthritis, and they recommended that these patients be treated for rheumatoid arthritis even before they made the old ACR criteria for it. So the new criteria is to try to help get there, and that there were substantial benefits to do that. Here's another study that looked at, is MRI-detected osteitis an independent risk factor for the development of rheumatoid arthritis? And the answer is yes. Osteitis was a predictive of the development of rheumatoid arthritis. The bone edema, but the evaluating the synovium was not. So the synovial thickening was not an independent predictor, but osteitis in the bone was. What is the value of MRI-detected tenosynovitis in evaluating patients? And what they also found is that flexor tenosynovitis had a high correlation with ultimately becoming diagnosed with rheumatoid arthritis. So if you see flexor tenosynovitis, that's also a pretty specific finding for rheumatoid arthritis in the right setting. What is the value of MRI and ultrasound in evaluating patients with undifferentiated analysis? They did a meta-analysis looking at all the published studies, and these are a real problem. And I think at this stage, these meta-analyses aren't very useful, because a lot of these are dealing with data that was published 10 years ago. And the use of MR, the technology that's employed is very different now than it was even 10 years ago. So a lot of the papers used for this are really outdated and no longer relevant. But again, they found that MRI erosion, synovitis, and bone edema increases the probability of developing rheumatoid arthritis in these patients. Absence of synovitis decreased the probability. So here's a list of different studies that looked at whether MRI could predict erosive disease. What they found here is that osteitis predicted erosive disease in all of these papers except two. One of these actually didn't evaluate osteitis. It just evaluated the other factors. This paper by Brown, the problem with this paper is that it did not have any fluid-sensitive images. It had no stir or PD fat set. So the technique couldn't detect osteitis. So neither of these papers really should be included. I included this one simply because it was a negative, but it was a negative because it didn't do the MR properly. All the properly done studies that have looked at it have found that that osteitis was highly predictive of erosive disease, and that's generally accepted right now. We also know from a number of studies, this is one of the better ones, that tight controlled using anti-inflammatory drugs leads to better outcomes, and that's widely recognized. So the dilemma is, many of the patients who can most benefit from drug treatment are the patients with early disease before they fit the standard criteria. So that's pushed people to develop a new criteria. The new criteria was published in 2010. Basically, you have to have at least one joint inflamed in order to be considered potentially having rheumatoid arthritis. So that's necessary before you do anything else. But once you have that, they look at joint counts, They look at the serologic findings, the duration of symptoms, and whether or not you have an acute phase reactant like CRP or ESR. And each of these are given a point. And then if the points add up to 6 or more, that's definitive rheumatoid arthritis. Now, there's no imaging in here, but after this was published, they said imaging in this paper might be helpful. But then a number of people wrote to the authors, and the authors basically came back with a supplement in Annals of Rheumatic Diseases, where they said that because of the increased sensitivity of ultrasound and MR, that MR and ultrasound could be used to determine the joint count, which is much more sensitive than the physical examination, and that it is appropriate to use imaging assistant joint counts in coming up with the score. And that then almost always increases the joint count and therefore increases the sensitivity. And they believe it doesn't change the specificity. So many people now use ultrasound and MR to help in doing the joint count and making the diagnosis at an early stage.
Does that mean you're going to image? How do you decide what joints to image then?
Yeah, that's good. That's a question. I don't have the study here. That's actually been looked at, and generally what's found is that you lose very little information if you image the hand and the wrist on the dominant side of the individual. Now, typically people will image the symptomatic joints, but if they're symmetric, a kind of generalized joint involvement, or if you're just trying to do a joint count without clinical findings to suggest a specific area, then it's recommended to do the hand and wrist of the dominant side. As a study by Østergaard and all from Denmark. Okay, so MR may be helpful in making the diagnosis. That's something we didn't believe in the past, but now it is. But it's very important in determining whether patients have a erosive phenotype. So early rheumatoid arthritis, detecting joint involvement, and it can detect osteitis and therefore the risk for future erosions. Now, detecting and quantifying synovial inflammation, ultrasound and MR are significantly better than clinical examination and plain radiographs in detecting RA patients in clinical remission who have subclinical inflammation and risk for structural progression. So there are a number of papers now that have done ultrasound and MR imaging of patients who are being treated and have complete remissions. So they have rheumatoid arthritis, symptomatic, they get treated, they have no symptoms, and then you follow them with imaging. And what happens is all of these papers have shown that a substantial number of patients who are clinically in complete remission will actually have ongoing inflammatory disease, and you can see ongoing destruction of the bone even though they don't have symptoms. So they believe now that following these patients clinically alone is inadequate to provide best outcomes. And therefore they recommend evaluating the patient with ultrasound and or MR, even if they have clinical remission. And if you start seeing osteitis or new erosions, then they need to go back on higher level treatment in order to stop the bone destruction. I think MR is much better because ultrasound can't see the osteitis. It can only see erosions, and I think you want to pick it up before you develop the irreversible erosions. So I think MR is much more recommended. The thing is that ultrasound is much more available around the world. It's in the clinic, and therefore there are arguments why that is better than not doing anything, especially if you don't have MR available, and it's a lot cheaper. So in areas where cost is a big issue, then you might want to go with ultrasound, even though I think it's suboptimal.
It's a big issue everywhere.
What, money?
Yes.
Yeah. It depends on whether it's my joint, I guess, or not. And then also there are people now who believe that we should no longer use clinical criteria to determine remission, that imaging should be included in the remission, and that you should not have a remission unless you have stable erosions and no osteitis. If you have any osteitis, even if you're clinically asymptomatic, then it should not be considered a remission. And that's being debated currently.
Well, a lot of folks take NSAIDs, aspirin, and other non-steroidals, and they may be not symptomatic because of that. and yet they have progressive disease. I don't know what these papers say about that, but I'm not read them.
I think a lot of them didn't control for for non-steroidals because that's not considered a treatment for rheumatoid arthritis, but a lot of patients might have been on them anyway. That's right.
So they found
Yep. So then there are papers that have looked at high field versus low field, looking at synovitis, effusions, osteitis, erosions, and so forth. And generally, what's found is for erosions, the field strength isn't that important. For synovial thickening, the field strength isn't that important, though you can see it better, especially with contrast at high field. I think everybody would prefer high field if you're looking at that. For osteitis, overall, both fields are very good, but there's probably a little bit of improved sensitivity at high field because of the increased signal to noise and spatial resolution that we can get with that. So, and the contrast for some of the sequences, some of the more modern sequences you can do at high field, I think give better contrast than the stir, which is what you're typically stuck with at low field. But anyway, field strength isn't really as important as some people try to make it out to be. So in summary, early diagnosis leads to better outcomes. MRI allows an earlier diagnosis and for early detection of the erosive phenotype, which then is what's really the big decision is whether they should be on TNF-alpha inhibitor or the biologics or not. Many patients in clinical remission continue to erode bone, and MRI, I think, is the best way to detect ongoing inflammation and the need for higher level treatment, even if the patients are minimally symptomatic. It's just a few studies here. There was a study that was in J-Room in 2008, which claimed that 41% of patients in Canada may not get optimal care because of the shortage of MRI scanners in Canada, that rheumatoids were put at the bottom of the list of who was able to get MRI in Canada, and they felt that when they extrapolated that back to patients in Canada, that was leading to under-treatment of almost half of all Canadian patients with rheumatoid arthritis. It's a systematic literature support trying to look at the how MRI should be used, and it basically said that there was no consensus that osteitis may be predictive of early erosive disease. The problem with this paper, like a lot of the others, is that most of the good papers are only in the last couple of years, and they used all the papers even going back for years before that. So they used a lot of data that probably wasn't very good data in this particular analysis. But the main thing that they came out with was that more study needed to be done because there is insufficient evidence in the literature to make a judgment one way or the other. This is a study that's in the process right now. That's being done at UCLA. And they used a much more rigorous approach to evaluating the literature. And what they found, it's been put in an abstract, and I think will be submitted in a couple of months to Arthritis and Rheumatism, as that 1.5 Tesla MRI was well validated in the evaluation of synovitis, osteitis, and erosions in the hand and feet of patients with rheumatoid arthritis. So I think this is the newer data that will be published soon. And the next thing they're going to do is look at lower field strengths to see if they can also show that it's validated at lower field strengths. And then there was one cost efficacy analysis that was in Archives of Internal Medicine, where they claimed that the cost efficacy analysis shows that MR is not there's not clear benefit from it. Looking at they made a number of economic assumptions based upon the people in it. Again, the primary thing that they said here was that there's just insufficient data in the medical literature to really do an accurate cost efficacy analysis for the value of MRI. A similar study was published in the orthopedic literature back around 1989. Also, and it showed, and they claimed that MRI was not cost effective in the evaluation of knee diseases. And again, it was because it was early inconclusive data. We then that led to a study that the American Academy of Orthopedic Surgeons developed, and I was the only non-orthopedic surgeon on that committee. And it came out using we'll talk about it later, a very robust technique to actually show that MRI was cost effective, that the value of MRI was about $2,000 per patient because that's what it saved. And we'll talk about the details. A second study done later, done at Yale, actually using a completely different technique, actually came out with the same monetary value of MRI. So I think at this stage, the cost efficacy analysis of MR and rheumatoid arthritis, you just can't really do it properly because the proper data is not available. And the bottom line, what happened with the knee, the first study said it was not effective. They said it was not effective because every patient, the study design was you would do an MRI and then all the patients went to arthroscopy and were treated. Well, there's no savings there. It wasn't until Yale or orthopedic department said, we'll do an MRI, and only those patients where the MRI shows a surgically correctable lesion will go into surgery. When they did that, it became highly cost effective. And we're at the same stage right now in rheumatology. There are no studies out there that say we'll use MRI, and based upon the MRI, we'll determine whether the patients will go on TNF-alpha inhibitors or not, and then see what the outcomes are. Primarily because the drug companies have been unwilling to support that, and the drug is so expensive you can't do it unless you have a drug company support. We've been fighting with them to try to get them to do that, and until that kind of data is available, you really can't do a cost efficacy analysis of MRI. So
I think it's far more important to make an early diagnosis with this awful disease than it is for a degenerative tear of a meniscus.
So any questions about MRI?
Consideration, right, is the cost, the loss of cost that that person has to society and to his job or her job. That is a huge, I would pay anything not to have hands like that.
Well, they tried to include those kind of costs in that one paper, and there's a lot in the rheumatoid literature of that, and that's really how they got Medicare to pay for the TNF-alpha inhibitor drugs, is that they found that using that you could save society money by paying for it because of the increase in productivity of those individuals. Yeah. But so they did that kind of analysis, but they said MR didn't change the treatment, and that's because there's no studies that have been done properly to show a role for MR. Just like in the early days of arthroscopy, if everybody goes ahead and has surgery, then it's not going to be cost effective. What happened is that Yale, and then the study that the AAOS decided not to publish, that we did with the AAOS, showed that MR was cost effective in a plausible clinical setting. But then there was a lot of feedback. That's why the AAOS wouldn't let us publish it, because the people thought that it might cut back a lot on surgeries. What turned out happening is a lot of people got MRI in order to make a diagnosis because they had knee pain. A substantial number of those had conditions that were thought to be treatable by surgery. So what ends up happening is that surgery didn't go down, surgery went up. Diagnostic arthroscopies went to zilch, but therapeutic arthroscopies actually increased in numbers. So what the AOS was concerned about didn't happen at all. It's just those patients who went to surgery for therapeutic reasons, not just for diagnostic studies.
Gave them an excuse to do more cutting jobs.
Any other questions? Okay, then it'll be 2 weeks from next Monday, and we'll do inflammatory disease of the knee. Then we'll finish all the knee except for the tumor talk. We'll do all the tumors probably in the spring. And then I think it's what I'd like to do is I have a talk on kind of bone metabolism and bone architecture that we'll do, and then we'll go into the shoulder. So 2 weeks from Monday. Thanks.
This has nothing to do with.
Thank you.
Yep.